dissected today the Lancet Commission in Nigeria recently that came on board for everyone to see, to everyone to read, and also see what exactly where we are today in the health sector of Nigeria that has not been very exciting in terms of the gaps and majorly things that have affected us as a people, and trying to fill those gaps with recommendations from this wonderful, which I call it, Bible of the medical world. Now, I'd like to say quickly here that what we're trying to do is accentuate the positive as much as we need to understand what are the gaps there. But of course, we hope that at each end of this seminar series, we'll be able to give visibility to what we should be doing so that we can accentuate the positive to push health sector delivery faster and accelerate access, demand, and of course, ensuring that quality health is available, not just out of pocket, but ensuring that indeed the universal health coverage becomes a reality in Nigeria. So I welcome all of us and say that it's going to be an exciting time, but we need to just have a few of these grand rules, erudite scholars, and of course our lead discussant for today would have a maximum of 15 minutes to deliver his paper. Our other panelists, we also have 8 minutes. Please drop your questions in the chat box or the chat room. That will be collated, and after we've listened to our erudite scholars, we'll now go back to that, and so we can have a robust interactive session. So on behalf of ISMPH and DGI, I welcome all of you. We're excited to have you. Thank you very much. I'd like quickly to say that we have participants across board, even outside the shores of Nigeria. So the seriousness that have been given to help to improving healthcare delivery service is what we are witnessing here today. I'd like also to thank our lead speaker, Professor Ibrahim Abubakar, our other speakers, Professor Obina, Professor Nasser Sambo, Dr. Amina Baloni, who is leaving the meeting to actually join this, that's the seriousness attached to it. Dr. Iberi Anyachuku, thank you so much for being there for us. Professor Bayo Fayoyi, and of course, Dr. Gafar Alawode, who is the team lead at DGI. And of course, every other participant is warmly welcome. We hope that at the end of today, we'll have a better understanding of the findings of what the Lancet Commission Nigeria has been able to put forward. And of course, going together and doing it together, I'm sure we'll do it better and faster. So without wasting any more of your time, I quickly would like to introduce our lead speaker, who would he would be the one to amplify for us the discussion for today. Please welcome with me warmly Professor Ibrahim. Professor Ibrahim is Dean, Faculty of Population Health Sciences and Professor of Infectious Disease Epidemiology at University College London, UCL. He's a UK National Institute for Health Research Senior Investigator and Chair, Lancet Nigeria Commission. He was Director, UCL Institute for Global Health, Scientific Advisor to the House of Lords, Science and Technology Select Committee, Science of COVID-19 Review and Scientific and Technical Advisor to the Nigerian Presidential Task Force on COVID-19. He led the UCL Center for Infectious Disease Epidemiology and was a senior investigator at the Medical Research Council Clinical Trials Unit. He was head of TB at Public Health England, where he led the UK government's successful strategy to control TB, and professor in health protection at the Norwich Medical School, Norwich, England. He qualified in medicine and trained in internal medicine and public health at famous Ahmadu Bello University, Zaria. the London School of Hygiene and Tropical Medicine, University of Cambridge, and the Norwich Medical School. He's a fellow and the Academy of Medical Sciences. He chairs experts and policy advisory groups for the UK National Institute for Health and Care Excellence, the World Health Organization, Wellcome Trust, the European Center for Disease Prevention and Control, and other international bodies, and has provided technical support to countries in Africa, Europe, and North America. He has published over 350 publications in infectious disease, epidemiology, and migrant health. Well, distinguished scholars, ladies and gentlemen, I'd like to present our lead discussant today, the scholar of the moment, Professor Ibrahim Abubakar. You're on and you're welcome. I hope the weather is favorable in England for you to join us this day. You have the microphone, you have the floor, Prof.
Thank you very much, and thank you very much for those kind words. So I would share slides and present from a PowerPoint slides if it's all right with everyone. Let's see, can I do that? Yeah. Can you see my slides?
Yes, Prof.
Yes, we can. Oh, yes. Oh,
excellent.
Yes,
okay. Okay, so I have 15 minutes to take you through a whiz tour of the Commission report that we published, which was launched in Abuja last month. To very good reception, I would say. I was delighted to be back home to talk about our recommendations. So the thesis of what we present is that it is the time for us to rethink health policy and reposition the country. And we see a vision where there's a future where our recommendations around health and wealth for future generations become policy to allow Nigeria to fulfill its potential. And we believe it is possible that if the various recommendations we set out are implemented, that Nigeria can move to exactly where we want it to be, i.e. the giant on the African continent. We all know that Nigeria is Africa's largest economy, but we also know it is necessarily not the case that wealth is always equal health. That popular adage that health is wealth is only true if in fact you can generate the right level of health so that people can be a productive labor and produce wealth. Nigeria's life expectancy at birth of 54 years is the 5th lowest in the world. And I'm not going to spend the next 15 minutes talking about the bad statistics. I would like to promptly move on to the promise of what we could do and what could be different. But it's important to reiterate where we are. We have more children under the age of 5 dying in Nigeria than anywhere else in the world. Our maternal mortality ratio is only worse than that of Chad, Sierra Leone, and South Sudan. And we have a massively growing population to levels that exceeds our economic growth. If you look at our burden of disease, you can see that a lot of the conditions that cause ill health in Nigeria are actually preventable ones. The sort of conditions such as infections and maternal and child conditions that can be prevented. We also have a growing burden of non-communicable diseases and a growing challenge with diseases of pandemic potential, such as Lassa fever that cause multiple outbreaks. The drivers of these chronic conditions, such as non-communicable diseases, are also things that can be tackled and prevented, including malnutrition, unsafe water, air pollution, and hypertension. And all of this can be addressed with population-level interventions. And the only way to do them is if health policy makers take a view that health has to be in all policies, because many of these issues are not primarily within the domain of the health sector. The impact of reforms to date, and there are many fantastic reforms, ideas on paper that exist in Nigeria, not least the primary healthcare under one roof initiative, the formal health sector reform program, the 2014 National Health Act, the Basic Healthcare Provision Fund. All of these documents contain numerous excellent ideas, but the extent to which we have actually implemented them is limited and in many cases stilted, in part because of the complexity and insufficient specification of who is responsible in our complex multi-tiered arrangement at the federal, state, and local levels. We also have to some degree fragmentation and limited accountability for actions by the different tiers of our governance. And for some elements of the health system, challenges with sustainability, because outside of the basic healthcare fund and our budgeting structures, sometimes the resources to support the system can be limited. As a result, our health system is actually struggling to deliver the needs of our population. Another tragic element of the current situation is the huge out-of-pocket expenditure, penalizing the poorest of our citizens. And despite the relatively large investment by the state compared to many of our neighbors, the largest proportion of expenditure in health is borne out of pocket, with further complication that the bit that is supported by donors is actually uncoordinated, so that the donor spending drives where money is spent rather than the state or government telling donors what to do. And we need to change that. In an accompanying paper published at the same time as the Lancet Commission, using the global burden of disease data, we show conclusively that it's not just about the amount of money, but it's also how we spend the money. Our health outcomes in Nigeria are actually worse than many of our neighbors. And it is true, even if you compare us with countries that are spending less than Nigeria in terms of healthcare. So that in a number of statistics across West Africa, we rank not at the top, but in the middle, or in some instances at the bottom. And this is inclusive of countries that are much poorer than Nigeria. So I'd like to move on to our recommendations to conclude the talk. And there are, before I do so, some examples of successes that we should be building on. Examples include the fact that if you look at life expectancy in Nigeria across all age groups, it's actually increased by about a decade between 1998 and 2019, and levels of disability have also decreased. So in the midst of all of that bad news I've communicated, there are elements of the health system and of society that are moving gradually but slowly in the right direction. I also think the opportunities presented by the Basic Healthcare Provision Fund and the federal and state health insurance schemes provide a superb starting point towards our journey towards universal health coverage. There are also other specific examples of success, outbreaks that the Nigerian state and civil society have tackled in a range of infections, including Lassa fever and monkeypox. The completion of major complex surveys that would take many countries a long time to deliver have successfully been done in Nigeria by NACA and international collaborators, and the delivery, despite all the skeptics, of Nigeria's polio-free status. Provide examples to show if we work collectively as a society with our traditional and religious leaders, it is possible to do this. So I'll conclude the talk with a few of our recommendations. The first one is, given Nigeria's young population, prevention should really be at the heart of our health policy. And the economic case for this is absolutely clear. Almost any public health intervention beyond health you look at that has implication in health provides superb value for money. And we need our political leadership to operationalize the idea of health in all policies to get prevention right. We need to make very strong incentive to invest in public services to create a healthy population. This requires that government functions properly to provide funding, governance, and communication. We need to empower our states and local government to look at a place-based approach to get these wider determinants of health addressed. And we need functional health units to be embedded at all levels, states and federal, to be able to implement a multi-sectoral response to the challenges. We call for this idea, which is sometimes difficult to communicate, but a really important one, that there are certain things that are better done once, and we call for what we call thoughtful centralization, such as issues such as standards, information systems, how you pool resources to strategically purchase from different sectors and the private sector in particular, and how you design your supply chains, really not to be done once and need to be done centrally. But there are many other elements that have to be delivered locally, including how we train our healthcare workers and ensure that they're embedded in systems, how we determine the minimum health packages, and how we ensure that they are amenable to local risk factors, and how they link into communities and the socio-cultural norms of our various peoples. We need those to be done locally, with oversight governance happening nationally. We need to leverage our vibrant private sector. We know, given the expansion of mobile technologies, for example, that Nigeria's private sector can deliver when it chooses to do so. And the state should incentivize the private sector to deliver where it's best placed. for example, in the production of vaccines, in medicines, and in health products. And we need to make sure that the private sector is appropriately governed by the states through initiatives such as strategic purchasing when we purchase things from the private sector and products. We need better health information systems. Our Lancet Nigeria process found numerous challenges when we tried to collect data at our hospitals and our health systems to analyze, and we had to rely on estimates in many cases. And there is a way to do that, and we think it is through digitization and ensuring that we use the fact that people have voted with their wallets using mobile technologies to design and adapt our existing systems, whether it is DHIS2 or SOMAS or NHLIS, and use mobile technology to get these to our healthcare workers and obtain appropriate information. We need healthcare worker planning and health resource planning. Of course, a large part of that is adequate remuneration for healthcare workers, but it is also about planning, thinking through at the state and local level, what healthcare workforce do we need? How do we ensure that we produce an excess of staff so that even if some leave, there's enough to meet our needs? How do you make sure that they're trained at the appropriate level and they're able to get licensed, tracked, and monitored at the state level so that we can plan for the health needs of each state and of our people? How do we work closely with the Ministry of Education and relevant regulatory bodies to ensure that it's not just medics and doctors, but all healthcare workers are appropriately trained and supported? We call for the idea that health for wealth. Health is indeed wealth. And we think that the way to do that is through adequate funding. And the number of things we support are legally ring-fenced budgets for health, building on the Healthcare Provision Fund, redirecting current inequitable subsidies, such as the petroleum subsidy that is crippling the economy of the country, to move in the direction that it delivers for people by being invested in things like health and education. And we think that it is time to mandate insurance at the federal and state level and think through how to implement that. We think that for the poorest Nigerians, it will cost the government about 1.2 trillion or 9% of the current budget to make sure that everybody has health insurance cover in the country. We model in detail the different scenarios to do so, and I will not go through these models, but they're available within the report for you to look at. But modest scale up in funding could lead to massive impacts and literally millions of lives saved over the next 2 decades if we do that, and we do that right in Nigeria. And if you move to the right level, you can in fact achieve universal health coverage. And we provide case studies in areas of the world where this has been done successfully for Nigeria to emulate, and examples of insurance systems that are doing relatively well within the state level within Nigeria. To do that, of course, we need to improve the fiscal envelope. Given the current revenue raised by the state in Nigeria, we probably don't have enough, and we provide specific ideas on how the state can go about doing that. Importantly, on this slide, I want to highlight the idea that we need to anticipate donor transition, and we need to prepare for post-aid status. Nigeria has the talent, resource, and wealth to lead the way in ensuring that our health is paid for through the wealth of the country, rather than depending on donors, and that we drive any contributions from external partners to the places we want them to be. I'm near the end in case I'm running out of time. So I think that we also need to take our rightful place on the African continent in terms of research and innovation. At the moment, other much smaller economies, whether it is Senegal or Rwanda or Kenya, actually produce high quality research at the global level that is of envy. And we have excellent research institutions within Nigeria that should be supported at our universities with specific dedicated funding. So we make the case that Nigeria should invest in specific research and innovation that allows us to claim our leadership position on the African continent. I'd like to finish with this slide, which is the ethos of our presentation, that as we go into the political season, there's an opportunity to call on our leaders to think through health as an opportunity to determine a new social contract between the state and its citizens, to use it as a unique political lever to say, we, the government and the governors of Nigeria, would invest in health with a view to ensuring that there is something in it for all citizens, which is the provision of good healthcare and long, good, healthy life. And we describe that as a system that is one nation, one health. And we hope that that would be the route to giving back a patriotic national identity and a sense of belonging from all citizens. I'd like to acknowledge all of our commissioners and our funders, as well as numerous other individuals that contributed to the collection of data across and within Nigeria and different parts of the country. Thank you very much indeed.
Wow. Thank you so very much, Prof. Especially working within stipulated time. I'm surely excited. You have given us a background of where we are and what we can do looking forward, and matching quickly. And that's why we tagged this conversation, translating knowledge into action. And these actions are what you have spoken to eloquently: a prevention, multi-sectoral approach, a political policy that will enhance healthcare delivery surveys, multi-sectoral approach, again, bringing in the private, public practice together in such a way that it will enhance the growth of healthcare, strategic financing, very important. Of course, again, using the technology. You also spoke to that thing that bothers everyone, brain drain in Nigeria. It's like we train for others to take. I look forward to a time when I can permanently bring you back home to continue what you're doing where you are. But most importantly, another huge gap which you spoke to and which is very, very important is medical research. Medical research has suffered in terms of financing and putting it in the mainstreaming it in healthcare delivery service. But overall, what's exciting for me is that you gave hope that we really can build a new social Nigeria, new Nigeria, where one nation, one health would speak, where it will be affordable, it will also be accessible moving forward. I thank you again, Professor Ibrahim Abubakar, and I hope you're staying behind so that we are staying still with us, so that we'll continue this conversation. Quickly, we will now go to discussion session, and we're still within the family of the Lancet Commission Nigeria. At this point, I'd like to bring on an erudite scholar whom, Prof, I hope that you remember that we met at one point, but here again would be asking you to share with us experience. And let me bring on Professor Obinna Owujekwe. Can I bring him on now, please? Thank you. Professor Obinna Owujekwe is a medically qualified, but also has master's and PhD in health economics. He's a professor of pharmacoeconomics and pharmacoepidemiology in Department of Pharmacology and Therapeutics, and professor of health economics, systems and policy in the Department of Health Administration and Management, both at the University of Nigeria, Enugu campus. He's an adjunct professor of health policy and systems with the Nigerian Institute of Medical Research, NIMA, Yaba, Lagos. He's the Director of Research at the University of Nigeria, the coordinator of the Health Policy Research Group, and president of the Nigerian Health Economics Association. He was the technical facilitator of the 2014 Presidential Summit on Universal Health Coverage in Nigeria. He's a member of board of the African Health Economics and Policy Association and the Health Reform Foundation of Nigeria, HEFM. He's also the director of the Nigerian National Center on Health Policy and Systems, University of Nigeria, which is part of the African Health Policy and Systems, which is part of the African Health Policy and Observatory Platform, AHOP, on health systems. He's a member of the African Advisory Committee on Health Research and Development of the WHO Regional Office, the Nigerian National Health Research Committee, the Ministerial Expert Advisory Committee on COVID-19, and the COVID-19 Social Economic Working Group of African Scientific Research and Innovation Council of the African Union. He was a commissioner in the recently launched Lancet Nigeria Commission on investing in health and the future of the nation. He's the editor of the African Journal of Health Economics. He has published more than 340 journal articles. He's a fellow of the Nigerian Academy of Science. He's also a fellow of the Academy of Medicine Specialties of Nigeria. Now, what's a profile? I leave the floor to you, Professor Obina, and let's speak to the Lancet Nigeria Commission provides evidence of the worrisome level of inefficiency in the Nigerian health sector, especially in the areas of financing, human resource management, and others. Now, what are the practical policy levels or levers that we should deploy to curb the inefficiency and increase value for money? What are the challenges associated with the deployment of such policy levers, and how do we overcome them? Over to you, Prof.
Yeah, thanks a lot, Moji, for that introduction. I think going straight to the point, see whether I can share my screen, but if it's not possible, there's no problem. Okay, I can't see my screen, but can you see it?
I can't for now. Yes, I
Yes,
can see it.
Okay. All right. So I just go to the first point is, we need to improve how we budget. The way we budget, both federal and state governments, is very inefficient. Those budgets are not, aligned to achieve anything. So I think the first practical step is to bring back this broad-based participatory medium sector strategy, which usually precedes the budget. I mean, this used to happen. It was introduced by when Bodo Agosto was the DG budget, 2006. And the budgets started becoming aligned to achieving the MDG then. But it involved, this budgeting involved, people getting part of, in all MDAs, ministries, CSO getting involved in the developing the MTSS, so that at the end, we had very useful MTSS, and then the budgets were derived from the MTSS. So we had budgets that were aligned to achieving something. And then the projects in those budgets, were well interrogated. But now we've gone back to the bad practice of budgeting anyhow. So I think one step is we need to bring back these broad-based participatory MTSS, which was very useful and happened previously. And then the second point, Professor Ibrahim has mentioned it, issue about how we need to improve our health financing functions. And I think the pooling, the way we pool funds, especially donor funds, is very inefficient. Everybody's just doing what they want to do, and then find people spending on the same things, or not spending, not pooling properly. So by the time we pool funds in a basket fund, then we decide where these funds will make the most impact and spend there. But the current process is not working. So the better pooling and connection of donor funds and even internal funds are quite important, including pooling funds within the basic healthcare provision fund. But I think where we also have a big problem is the purchasing. When we get this money, what do we do with the money? So this is where we have a lot of inefficiencies because just like in the budgeting, we just use the money to buy things without thinking about what are the ultimate health system goals of the things we're buying with this money. So we need to become more strategic, in deciding on what to buy, who to buy from, and how to buy. One example is even in reforming how providers are paid within health insurance schemes. Capitation is the best way, but we need to make sure that this capitation is used properly to achieve set health goals and improve population coverage. I mean, we saw there was a very good program, the National Health Insurance Scheme, MDG program, that ended in 2015, where capitation was used to pay, and that program was very efficient. So we don't really need to reinvent the wheel. Some of the wheels have already been invented. We need to go back and see how we improve on them. The other way is we need to reduce corruption. And corruption comes in so many ways. The typology of corruption, we have both health worker absenteeism. People don't go to work, but they get paid. That is corruption. We have informal payments. We have employment-related corruption, where people who are not qualified positions are put in positions. These are all corrupt practices. So we just have to admit that the system has a lot of corruption, and then if we can improve efficiency without reducing corruption, of course, we know it's impossible to eradicate corruption, but we can eliminate it and make it so very low. So I think that's another practical step. And then in reducing corruption, we have what we call the vertical means. Vertical is top bottom, which we have now, but there are also horizontal mechanisms where we can actually, at the health center level, at the hospital level, we can involve CSOs, we can involve community groups to monitor what happens in those health centers, those facilities, and have a way for them to report back, and so that things are done, either to report back to the health facility. So, and these horizontal mechanisms most times are low cost. It involves communities, it involves CSOs, and it's possible to use them to reduce corruption at certain levels. And then this brings to the next point, is that we don't really have good accountability mechanisms in Nigeria. And these accountability mechanisms is not just for the public sector, but for even donor funds, with donors pumping millions of dollars. But there's no, what's the accountability? Who is involved? Are CSOs involved? So until we have a broad-based accountability mechanisms that involve CSOs, involves all kinds of people, not people forcing themselves to know what is happening, but they are part of the system, then we will start having an efficient system. But right now, people are working in silos, nobody is looking at what is happening, and then CSOs are not involved. And that brings also to the next point, it leads that the system has to be transparent. When we have an opaque system, the way we have in the country right now, it will never be efficient. So there has to be a way. We have this open government portal and all that. We need such systems, where all the spending, where the money comes from, how they are pooled, and what they are used to spend, what the health services they are used to purchase, are clear to everybody. So when they click on the button, we can go there. I don't need to go to court and file a case for Freedom of Information Act to allow me to know what is happening. So for instance, for the Basic Healthcare Provision Fund, there should be an open platform that everybody who wants to know what is happening will click on it and know how much has come in through the 3 gateways, how much has gone to every state, what have those states spent this money on, and who are the beneficiaries. Right now, billions have been spent, but nobody knows the beneficiaries. If you ask, who are the beneficiaries? So until we have this transparent system, database system, Professor Ibrahim mentioned it, we need a digital database system that makes clear that everybody has information that they need. And then that brings, so the next point is that to improve efficiency, I think it was mentioned in the report, and it's a big issue. Let's put the money in the hands of the consumers. Let's buy a health insurance premium for Nigerians, and then let the public and private sector get their facilities ready. So if you're not ready and you're not accredited, well, whether you're public or private, this premium will not get to you. So, and then once you put this kind of market mechanism, it will improve a lot of, introduce a lot of competition amongst various providers. And then, now the providers will be chasing the consumers, unlike what we have now. People are just giving by capitation, and then no matter what they have. But if this premium, the funding is paid, is used to pay premium, then I think we'll start seeing a lot of improvement in efficiency and equity too in the system. And I think I think the other point I want to make is we need to mainstream health in all sectors. It's a very big point in the report. Just the way gender has been mainstreamed in all sectors, health is also very important. And once we mainstream health in all sectors, so in agriculture, in everything, because from the report of the Social Commission on Social Determinants of Health of WHO, I mean, it's shown that a lot of things that affect health are actually outside the health system. So until we mainstream health in all sectors, we will not tap into the full range of possibilities and efficiencies that can accrue to the health system, because it will reduce a lot of duplication in efforts, you know, and then there'll be a lot of savings if we reduce duplication and if we integrate more actions for improving health across sectors. That will improve efficiency. And I think I just want to say that, you know, we have a lot of money in Nigeria within the sector, health sector. The problem is that we are using this money inefficiently. We've seen millions and billions of naira and dollars come in, but they have not yielded the much needed effort. And I think this is the two-pronged effect of inefficiency and corruption. And though we think that more money, though we know that more money will be used, is necessary in the system, but we need to improve the governance of this more money. If we pour in more money into the current governance systems, we may not achieve much. So we need to implement some of these practical steps to make sure that the system will be efficient and will be, you know, we have minimal corruption. Then additional money will be useful. Otherwise, I think we can achieve a lot with the more money we have already. So we can achieve more health for the available money if the systems become more efficient. And then more money will make more sense if the system is able to become more efficient, transparent, accountable. Thank you very much.
Thank you very much, Prof. Thank you so very much. You know, articulating things that are doable, I would say, particularly pulling resources together, which is very important. You are looking at the need for us to start looking inwards because we shouldn't be donor dependent. I think both of our speakers have spoken to that. Then tracking the money to ensure that the resources available are even well utilized. So that's where transparency, accountability comes in, and of course, equity. And another thing that he said, which is very germane, is the need to mainstream health in all sectors of the economy. I think this is very, very important moving forward in terms of making health available when we need it. Thanks, Prof. Since we are going to share every presentation with, we're going to share it as much as we can. I would move on now to our next speaker, also a panelist today. He has, in fact, I would say that he got in here before everyone, so the seriousness which he applies to these webinar. Please welcome with me Professor Mohammed Nasser Sambo. He's Executive Secretary and Chief Executive Officer of the National Health Insurance Scheme. Before his appointment, he was the Provost, College of Medicine, Kaduna State University. Prof has done a lot. He's the Professor of Health Policy and Management. But let's come quickly to where he holds forth today and what he's been able to do in the last 2 years. Professor Sambo has been able to reposition the National Health Insurance Scheme within the ambit of the famous word that is common with everyone, health insurance under one roof. Now, that's his dream, and that's what he's been trying to push in repositioning and ensuring that you know, facilities are equipped, facilities, people have the wherewithal to get treatment when needed. But for this webinar, Prof, I'd like to ask, according to the Lancet Nigeria Commission report, the existing health funding landscape will not set Nigeria on the trajectory of universal health coverage, which is our dream. And there are recommendations from the report on potential new sources of financing for the country's universal health coverage quest, including telecom, tax, oil subsidy, reinvestment, and other such interventions. Now, what are the practical steps needed for harnessing these potentials to expand health insurance coverage to the teeming population of Nigerians? What help does the National Health Insurance Scheme need in this direction? Prof, you have the floor. Professor Sambo, Executive Secretary, National Health Insurance Scheme, Nigeria.
Thank you very much, G, and all the commissioners. My task is very simple, and I want to start by trying to highlight some of the facts that has been contained in the Lancet report, which has to do with understanding the evolution of the health system, the political economy context, the epidemiological context, social determinants of the healthcare in Nigeria, and the drivers of the burden of diseases. Issues that has to do with governance and structure, issue that has to do with human resource on health, health infrastructure within the context of COVID-19. We've all seen how vulnerable Nigeria is in that area. Then dwelling on my area of focus, which has to do with healthcare financing. The healthcare financing in Nigeria from the Lancet report is not one that can give the trajectory for ensuring effective healthcare delivery system. So in discussing this, we need to quickly look at what are the current healthcare financing strategies in Nigeria. We have the general tax revenue, and tax can come from direct and indirect taxes. We also have health being financed through social health insurance, the donor financing, donors by philanthropists. We also financing through philanthropists. We also have financing coming from the multinational corporations, the private sectors, and so on and so forth. But the out-of-pocket expenditure is very, very high, accounting for 78% of the total health expenditure in Nigeria. This is very, very retrogressive. Why do we say that this is retrogressive? If we want to assess the criteria for financing healthcare, there are well-established criteria. Number one, what is the capacity of that financial option to mobilize fund? Number two, to what extent that financial option can engender efficiency? Number three, to what extent the financing healthcare can be equitable? And equity in healthcare financing can be vertical or horizontal equity. So if you look at the equity from the equity perspective, you will recognize that the out-of-pocket expenditure is very, very retrogressive, in the sense that you are tasking more vulnerable people to pay more for the healthcare delivery system. Looking at the epidemiology of diseases in human population, you see that the poor people are more susceptible, are more vulnerable to healthcare delivery system, are more susceptible to healthcare problems. And therefore they will have to be visiting healthcare facilities more than the rich. And at the end of the day, you will see that the poor people are paying more for healthcare. And if out-of-pocket expenditure is the mainstay of financing healthcare, then that issue of pushing people into financial catastrophe is there. And the health insurance among the healthcare financing option is found to be the most progressive healthcare, because it has both capacity to engender vertical and horizontal equity. In health insurance, the underpinning philosophy is that the poor contributes into a common pool. There is a pooling of risk, and there is a pooling of disease and of resources. And once this pooling is achieved, you realize that the poor will pay less, and invariably he will have to seek for more to sell healthcare more. So he will now be benefiting from the contribution that is made by the rich, and so on and so forth. That's why health insurance is a vehicle, veritable vehicle for attainment of universal health coverage. And therefore, the practical steps that we need to do in ensuring that we mobilize resources for healthcare delivery system is one, to ensure that every policymaker and every Nigerian see health as a key issue of development. If we all see health as a key issue of development, we will not have any problem to ensure that we invest in the healthcare delivery system. And we must tag that investment to the fact that a healthy nation is a wealthy nation. And wherever you have an unhealthy nation, it will affect the productivity of a country. And therefore, it will affect even the gross domestic product of a particular country. So we must see health as a developmental issue, and should have capacity to invest in that healthcare. And we must recognize the fact that if we refuse to invest in healthcare delivery system, we will run a risk of spending 10 times more resources that we ordinarily would not have spent if we have invested in the healthcare in the first place. Secondly, we need to all understood the philosophy underpinning universal health coverage. Our policymakers, our policy implementers must understood that universal health coverage is a global goal that every country must try to achieve. And therefore, we must pay a lot of premium to universal health coverage by ensuring that UHC is placed high in the agenda of our policy development. By policy development, I'm talking about whatever policy is coming at the national level, the UHC must be given a premium. And we therefore also need to invest how much and do a quantification, how much do we require to attain universal health coverage? And given the existing healthcare financing parameters we have, how much is coming to the healthcare delivery system? And what are the gaps? We must work toward attaining, of covering the gap.
Prof, you have 3 more minutes. 3 more minutes, please.
Okay, we must be able to cover those gaps. So having understood the importance of health and importance of universal health coverage, what is NHIS currently doing? NHIS will help in ensuring that funds are generated, are pulled together, and there is strategic purchasing of healthcare delivery system. NHIS is working toward attainment of mandatory social health insurance so that everybody will come into the health insurance ecosystem. And it is only through that you can attain universal health coverage. And for NHIS to perform this critical role, it must be a stable organization. And that is what informed our 3-point rebranding agenda of the National Health Insurance Scheme. Because when we came 20 years after, NHIS has covered only little segment of the population. So NHIS can work towards of having a mandatory social health insurance scheme, and NHIS must spearhead development of different policies that will cover different strata of the population. NHIS will have to ensure that there is monitoring and effective coordination of state health insurance agencies. These are agencies that are supposed to drive health insurance at subnational level. And NHIS should also help in being creative and innovative. Creativity in the areas of health insurance under one roof, which is a very novel idea for coordinating social health insurance. Digitalization of healthcare system. We have been able to develop an overarching health ICT infrastructure that can host the entire data of Africa, health data of Africa. NHIS can also spearhead other innovation in form of drug supplies. We have currently developed what you call NHIS drug system, whereby we partner with manufacturers to begin to produce drugs that are qualitative and make drugs available for consumption of all people in Nigeria through branding and bringing down the cost, and other initiatives like gift ship program, which can cover all the entire informal sector segment of the population, as well as even our kids and kin in diaspora. And I want to pause here. I thank you very much for giving me opportunity to talk.
Thank you so very much, Prof. I know that with you, it's about passion and articulating what is possible, considering the fact that our ultimate goal is to achieve the universal health coverage. Thank you for all those options that you have reeled out. We would not just stop at this conversation, would ensure that we give it a loud voice, a louder voice, so that people, Nigerians, can key into it. And you have spoken to a variety of things, but I'd just like to bring the key issue of development, making health a developmental issue. And of course, you also emphasize the need for us to pull resources together, which of course would bring about availability of quality medication in country. I think this is a wonderful innovation going forward. We'll continue to meet with you because it affects all of us, and doesn't matter whether you're healthy today, it is that you can get health. You can when you need it, and this is what the promise that you have made in your presentation. Thank you very much, Professor Nasser Sambo. We are moving on now, and we are just going to share what the Lancet publication has to say in terms of what is doable at the state level. And to lead us here is Dr. Mohammed Baloni. She has over 25 years of practice as a clinician and a public health professional. Her core competencies of communication, drive for results, and working with people was honed during her years in developmental work, which has helped her achieve results while working with the government in various states to improve the health and well-being of children and women. And this is really my own passion, by building their capacity and transferring technical skills such as planning, analytics, formulation of strategies, and monitoring for results. She's a foremost professional. She's a team player, and as we speak, she is the Commissioner of Health in Kaduna State. And I understand that you had to take permission to be on this program today, jettison a call in office to be part of this. Thank you very much. And I'm sure you will amplify the voice of women. You have the floor, Dr. Amina Baloni.
Thank you very much, Auntie Moji, and thank you very much to the organizers of this webinar for inviting me to speak on such a very important topic, and also a very important and timely intervention towards the health sector in the country. I would like to thank the contributors of this work, this body of work, which has been very robust and truly has x-rayed the health sector and the various issues that arise from the fact that we have a fragmented system, we have a system that is not working at optimum, and what are the ways that we could really support the health sector to do better. I think all the recommendations that have been made by this paper are really useful and germane. And to say that if we systematically apply these recommendations and focus our energies and resources into implementing them, then we would really make a lot of progress. So coming to how states, or what in my experience states can do as policymakers, what we can do to really move this forward. I've looked at the recommendations. To look at the first one, which talks about the standards, the policies, which should be set at national level. This is what should apply, and it has to varying degrees applied. But what we've tried to do in Kaduna is to look at what are the national standards, what are the national policies, and how do they affect Kaduna. So we try to domesticate and contextualize these policies and adopt these standards for use. This is key because having different standards means that we really don't have a particular benchmark on how we can deliver services. So building on this, I think it's very important at state level and making sure that you take in state context. Things like the health policy, the supply chain policy, and even the PPP policy, the states has recently domesticated that. In talking about training and how this should happen at state level, I quite agree with the recommendation that training needs to be contextualized, one, and two, it needs to consider what the skill mix is at state level, what the gap is at state level. So some work needs to be done to establish what are the baselines in skills, what are the baselines in requirements, and what is the training that is most appropriate. Here you can also think about the task shifting and task sharing policy, which is supposed to be implemented. The only caveat there is that we should have an exit for task shifting and task sharing and making sure that we're transiting from immediate needs to what the long-term future needs are. In terms of health financing, that's very important. At state level, most states have the social health insurance. What we have in Kaduna is also one of those. It's started operating in 2019, and of course was slowed down a bit by COVID. But we have enrolled just under 1 million people, far cry from the 10 million people that we have. But most of the people that should get health insurance, which are in the informal sector, are out of the net. And that is something that we focused on. We've started a lot of aggressive mobilization and campaigns. That, I think, will really bring in funding to health. The state government has earmarked 1% of the consolidated revenue fund towards the vulnerable populations. We also have a free maternal and child health pool. We're working towards how do we put these together in one pool? Because if you look at the basic healthcare provision fund and the provision for the vulnerables, there's some overlap. How do we maximize these resources to make sure that we get more people that are vulnerable under the net? For data, I think it's spot on. We've always had an issue with data, data timeliness, data, the cleanliness, so to speak, of data. Data is usually collected, people feel, for whoever is funding the program. And we're trying to change that mindset. And I think we should change that mindset to get people to understand that this data is for you and it's to help you to plan and to develop your programs and to see, even to monitor what you're doing. And what we've tried to do is do a lot of hand-holding at local government level where the data is generated, where the data is poorest. And we've at the primary healthcare level, we have mentors that work with the in-charges, work with the LGA M&Es to make sure that this data is actually being used as it should be. I totally agree that we need to focus on prevention. This is what primary healthcare, one of the linchpins of primary healthcare is. But looking at the paper and seeing the evolution of how our health services developed, you can see why we haven't really done very well in prevention, and we've been struggling ever since. So we need to harness more, looking at how do we change health-seeking behavior? How do we change behavior that ensures that we're imbibing behaviors that will be useful for health? And there you need, as Professor Sambo has talked about, the social determinants of health. Those are very, very key and important to make sure that people are taking care of water, sanitation, housing, nutrition, though health related, but other sectors that will really impact on health. We have in the state an integrated demand creation strategy, which we have, which is homegrown. And what this works at is how do we engender household change in behavior to impact on health, and how do we map and also link communities to services, and how do we make them own the services so that there's maximum utilization, there's monitoring of the services that are being rendered, and there's also a feedback loop to the health workers and ultimately to the policymakers to make sure that all the information we're getting at the community level is being translated into better services. HRH, I think, is the weak link in provision of quality services. We've recently heard, we know that there has been steady loss of health workers, both internally to the rural areas or to the federal facilities, so to speak, and then to external sources, which we've seen very recently. How do we work on that? Because unless you have quality HRH, you are not able to actually provide quality services. And so what we have tried to look at state level, and I think a lot of my colleagues are doing that, is what do we have first of all? How can we take the present resources we have? What tasks can we shift? How do you have the supervisory network that will look at these cadres that are being given tasks that are shifted from a higher level to make sure that these are done in a qualitative manner, or else we lose the whole essence of the task shifting and task sharing. And like I said earlier, we have to have an exit. I know that the Thailand model of having primary healthcare workers transition after some years to regular mainstreamed health workers, I think is very important, because we're in danger right now of having too many lower cadre staff that can transition and are not being utilized. The other things we've thought about is how do we incentivize communities that have low poor indices, for example, lots of children dying, lots of mothers dying. How do we get them to be involved? How do we take some of their staff, their community members, and train them as community midwives so that they serve their communities? And this, we're working with the local government authorities to see how this can be done. The last one that I think is very important is the public-private partnerships. As you know, most for Kaduna at least, we have a lot more I wouldn't call them private facilities. They masquerade as private facilities, but we have a robust number of public facilities. And I agree with the paper where it says that we need to primarily first focus on public facilities while we bring in the public sector for innovation, for purchase of services. I know that there's a drive to say, okay, send it to the private sector. But if you look at the private sector that is providing healthcare, a large proportion of them are actually not healthcare providers. They're just providing service. And those are probably some of the reasons that we get a lot of complications by the time they come into the public sector. So how do we improve the private sector that are providing services? How do we set standards? How do we regulate them? And then how ultimately do we share services with them? We have a lot of private providers that have been assessed and are providing health insurance services. but we find that when we do the quality assurance checks, that they're not doing so well. And I think there's a great opportunity for all the support that has gone in this state to the primary healthcare, to revitalize it, to upgrade the 255, to provide drugs and consumables, to actually build them up using health insurance. The other partnerships we have are with, like Prof mentioned, with the PMG man, who are manufacturers of health products and commodities, and we are getting from them drugs straight from the manufacturers, good quality, assured quality, lower prices. And as we expand, we're doing essential medication right now, but as we move forward, we will get into branding as well. And of course, with Zipline, where we have a partnership to deliver essential commodities like blood products, vaccines to hard to reach and high risk communities, especially with the insecurity, to get things that are needed for health to get there. Multi-sectoralism is key in Kaduna State. The Executive Council has a sub-council called the Human Capital Development Council, which puts in all the social sector MDAs, health, education, water and sanitation, local government, the social protection office, and a host of others that actually work on the determinants of health, social determinants of health, and in a manner that it meets every fortnight to discuss human capital development issues. How does water and sanitation impact on health? And that forum has greatly improved the intersectoral collaboration between MDAs that ordinarily may work in silos. For example, we've looked at the health, the education sector and the production of human resources for health. What do we actually need? And we're trying to tailor the needs at community level for community health, essential workers, and so on, to make sure that we're producing what we can, what we need. The other thing we've also introduced is bonding. We're introducing bonding of those community midwives. We train them and we bond them to work in their communities. And we also get communities to bond, their own HR as well. So excellent resources in the Lancet series. Very succinct recommendations and suggestions on how to go forward. I've tried to highlight a little bit of how we're taking some of these recommendations. And of course, with the paper, it gives us a chance to nuance what we're already doing to make sure that we achieve this universal health coverage that we've all committed to. I thank you for the opportunity.
Wow, thank you so very much, Dr. Amina. Thank you for all, particularly the partnership that has evolved as a result of, some part of the recommendations falling within the recommendations of the Lancet Nigeria Commission publication. But for me, the take home here is the multi-sectoral approach to healthcare delivery in your state. I do hope that we will be able to articulate this for other states, to follow in line. I want to congratulate you for what you're doing and hope that, you also spoke to the challenges associated with data. Data has become one that everyone should actually work at, hoping that that will help us plan better. And of course, promoting health-seeking behavior that also will go a long way to promoting prevention, which ultimately should be where we're going, considering that say between 65 to 70% of all the diseases ravaging us as a nation are preventable. So thank you for all the good points that have been made. We would include these as we move forward, particularly to achieving the universal health coverage, ensuring that we exchange good practices amongst ourselves and states and in fact, even the private sector. Now we're moving on from, we're leaving Kaduna now, and we're back here in Abuja. Next panelist is Dr. Ebere Anyachukwu. Is an advisor at the UK Foreign Commonwealth and Development Office, formerly known as DFID. Over the last 3 decades, he has been actively orchestrating, developing, and supporting transformative health systems and financing reforms, which have helped expand access to life-saving health services, and including maternal and child health, malaria, family planning, HIV, and others. He is particularly interested in strategic health reform and financing human resources for health and public-private partnership in the health sector, which are all the things that we have been speaking to since this program started. Now, Dr. Ebere, the question is, the study says foreign aid has led to fragmentation of the already complex health development landscape, with huge asymmetries in legitimacy between foreign actors and the Nigerian state, as well as weak accountability. Against this backdrop, how do we deliver aid differently to stimulate domestic and sustainable financing for health, promote efficient utilization of resources, and enhance mutual accountability? In other words, how is the FCDO promoting the concept of aid effectiveness? Thank you, Doctor. You have the floor.
Thank you very much, Moji, and thanks for that really important question. Yeah, I just like to say first that I think that the Lancet Commission was really came at the right time. Its conclusions and recommendations really spot on a number of the areas, and we're very much in tune with what they came up with. On the effect of foreign aid, I agree. I mean, the way foreign aid is currently being delivered in Nigeria has a lot of implications for the actual efficiency and outcomes that we see from aid. But there are really fundamental issues here. I think part of the problem is the lack of effective systems that transform funding, which is essentially what funding aid, foreign aid is, to outcomes. So, for instance, if you were to look at the Global Fund, which essentially is a funding mechanism, which wants to achieve outcomes in AIDS, TB, and malaria. The problem is, without a functioning system that the Global Fund can actually put that money into, and that will transform that money into those outcomes that they are looking for. Those are some of the issues that have caused some of these aid mechanisms to develop parallel systems that they can be sure of to actually transform that funding into outcomes. But this has a number of implications. It has implications for the efficiency of that work. It has implications for actually driving the work that is done at country level into what the donor wants rather than what the country actually needs. So there are implications of this, and I agree with the conclusions of the Lancet commissioners on this. But also, I think, and we've recognized this as donors. I don't think there's any donor that will tell you that the system that currently delivers aid is the most optimum that we could have. So over the years, what we've been trying to do is to build that system that will transform the aid that we deliver into health outcomes. So for instance, over the years, for more than a decade, we've been supporting the National Health Act, which is embedded into it, the Basic Healthcare Provision Fund. A lot of the work around that was actually led by FCDO, and the reason for that is that system actually provides that mechanism that allows us to, rather than develop our own parallel systems, instead support a nationally led system that can actually transform the funding that we are able to provide into health outcomes. And we also recognize that aid funding can be transient. Sometimes it's not the most sustainable funding that you can have. For one reason or the other, and a donor might decide to switch to different priorities, and a country like this really shouldn't be dependent on that. So one of the things we focused on is to help build those systems. So for instance, the BHCPF. Another thing we've helped to support is the primary healthcare under one roof, which was hugely supported by FCDO. And what that does is to offer, is to try to tackle the fragmentation of primary healthcare, which is one of the main constraints that we faced over the years in trying to improve PHC, so that you can have one single point of funding, of management, of accountability for primary healthcare. It also makes it easier for organizations like the NPHCDA to support primary healthcare across the states, rather than NPHCDA building, working with 774 local governments. They can support, the State Primary Healthcare Development Agency, which would then have the responsibility to build up primary healthcare delivery across the state. So that's another thing that we did. Also, if you look at the area of commodity supply, in some of the countries where we work, you have functioning systems where you provide funding to a state organization, and that funding does all the procurement of commodities, does the storage, does the delivery to every health facility. That's a more efficient way of working. In Nigeria, those systems are not existent. So you've had donors try to set up their own systems to actually procure and get commodities down to health facility level. That is not the most efficient way of doing this. So one of the things we did in a number of states was to set up sustainable drug supply systems. Some people call it drug revolving fund systems, which involved a lot of things. It involved setting up procurement systems in those states, independent drug agencies, financial management systems. It involved supporting all the health facilities to have bank accounts and stuff like that. Very comprehensive reform. And you have this functionality in many states, which then enables any donor to decide, okay, I can support this system rather than having my own system to get drugs or commodities to every health facility. We've done the same also for in human resources for health, where we've looked at, and as the Lancet Commission mentioned about some of the problems with human HRH and the constraints that the midwife service scheme faced. So one of the things we did was to support states to actually begin to train health workers coming from those rural, hard-to-reach facilities health workers that would actually stay in those facilities when they are trained, and that will be supported by the community and the political system. So that we found that was a much more sustainable way of delivering these outcomes than just importing midwives and putting in those facilities. I mean, in future, one of the things that we would really like to address is the issue of in-service training. So you have different programs. You might have an immunization program or a malaria program or one other COVID program or whatever. You go to a state and train health workers in a number of local governments. Another program would train them on something else. Another program would train them on immunization or whatever. At the end of the day, you have no idea who's been trained on what. It's a very inefficient system. But it's there because you don't have a coherent system for how will I call it, training of continuous improvement of the health workers. So our ideal will be in each and every state to have centers that are supported by all donors, where all the health workers are on a schedule and they go there, maybe spend a week and do all their training, whether it's immunization, whether it's family planning, whether it's this or that, and just do it. And they all do that rather than these ad hoc trainings supported by different different donors and different partners, which I think is really inefficient. And if we do it that way, we can spend much less on that, cover all the health workers. You have a database where you know which health facilities and which health workers have been trained on what, and you can use that money much more efficiently than we are currently doing. So, okay, great. So those are some of the things that that we've done in the past, and we think need to be on the table. But it takes cooperation between donors and the government, both federal and state governments, to actually deliver these systems, because some of these things actually drive a lot of incentives that are not always positive, you know. So one thing I particularly like in the Lancet Commission was around this whole talk about the social contract. And I think that's a very important point, because Nigeria is going through a period where the social contract is under attack. There really isn't any viable social contract, and that's why we have some of the instability that we are seeing. And I think health can play a big role in this, but it's something we have to really think through, how we get health to begin to form, you know, the core of that social contract, like the way you have in the UK, where the NHS is actually probably the biggest part of the UK social contract. There's an opportunity to do that in health. And I think we need to think through how we achieve that. Thank you.
Well, thank you very much, Dr. Ebere. You tried as much as possible to speak diplomatically. I can understand that. But seriously, you've also spoken to the challenge in terms of building a strong system that we allow things to work. And I agree with you. And also highlighting the need for capacity building within the system, particularly in human resources. I think it's important going forward. Thank you very much for your input. I'm sure it will go a long way in helping to improve the healthcare delivery system, which is why we're here dissecting and putting forward the best practices as recommended by the findings of the Lancet Commission in Nigeria. We are moving on quickly, and at this point, I'd like to introduce Professor Adebayo Fayoyi. He's an expert in development communication, media systems, and policy advocacy. He has nearly 30 years of professional experience in designing, implementing, monitoring, and evaluating public information and social and behavioral change communication interventions. He has worked with agencies USAID, UNICEF, and UNFPA. He has also accumulated over 20 years of full-time visiting and honorary teaching experience in several African countries. Prof, before you come on, I'd just like to again remind our participants that please drop your questions and maybe suggestions if you have any in the chat box, so that we can collate, and as soon as the panelists are done, we can quickly have the interactive session together. Thank you. Now, Professor Adebayo Fayoyi, you have the floor. Thanks.
Thank you very much, Muji, for inviting me. So you can see me. I'm of internet connectivity. I'll just switch off so that at least I can consolidate my broadband. I think a starting point for us is back to the report. And so what does it say? The report is very robust. It gives major recommendations on the challenges that we currently have with the public health care reform system. It says that the various attempts have been undermined by, one, failure to engage communities effectively, to raise awareness. It says that we haven't clarified responsibilities, individual responsibilities effectively. It says that the various inputs for reform processes haven't been consolidated. It also says that there is inadequate access by different groups to print and digital media for communication. Access to media has tended to be lower in rural settings than in urban settings. We have had challenge of information, health information flow, evidence-based information. It says that there is inequitable access to all these types of information. Access to media and technology has also been weak. Part of the challenges we currently think, because they will form the basis of the recommendation, that we needed more efforts to be able to address those inequalities and inequities as far as the information technologies is concerned. Many communities have broadcasting structures, but the information structures haven't been available at the rural level. Electronic media has been there, but we haven't had consolidated, consistent targeting of information and education to raise awareness. Faith-based and religious-based critical change agents, the report says, and they are critical for changing norms and informing behaviors about health. And we've seen them work in other areas, and therefore, as gatekeepers, they need to be effectively engaged through a power of networking. And I think finally, it talks about concerted advocacy and engagement at various levels, at the national level, the state level. Thank the Commissioner for Kaduna State talking about the multi-sectoralism that was critical in ensuring that certain Nigerians are moved in the state. So again, as far as communication is concerned, those concentrated actions are critical to be able to push for norms that are supported critical in elections. And how do we hold politicians accountable? Yes, they sometimes can be slippery, but of course, because they need to be held accountable for some of the actions that they've taken. So within this context, we start looking at some of the major actions that are critical. One, for me and to achieve results, we need multiple actors for multiple action, multiple actors for multiple actions. And so if you look at the whole gamut of actors and institutions and structures that we need to engage with, that is very critical. Because for us, if you're talking of actions, we need critical individuals to be able to help us do that. The executive, the legislative, the various NGOs. I think Ebere was talking about engagement of NGOs, even at the media level and the social change level, we need to do that. So engaging the mass media and the social media, we're in a digital world, and I'll be talking about that shortly. So very Policy communities that generate reports, fine, but we also need to enhance policy entrepreneurs that are able to help implement actions and turn knowledge into action, essential. The private sector organizations, critical, especially the media private sector organizations, critical in the entire process. And the various influential advocates that we're having, both activists, technical professionals, and even the beneficiary groups. So, in terms of going forward, turning knowledge into action, moving from just think tank to action tank, to have multiple actors for multiple actions. Next is strategic engagement with the political class, political leaders, political leads across the board. We know that political decisions are driven not by outcomes per se, but by values. And sometimes there is lack of skills, lack of culture for rigorous application of evidence, even in the public sector arrangement. And many of the policy leaders have low level of understanding. So we need to find processes to interrogate this highly robust report very well with the various sectors in the policy domain, so that at least we're able to see how we can institute actions effectively. And we also know that some may be perceived as that's just those theory people talking about evidence. So I think we need to be able to ensure that at least they fully understand it and then they go to act on it. Also, we know that political timetables are different from evidence timetable, and therefore we are at a good point now where we can ensure that we engage with the various processes in the political domain to help us enhance the actions through parliamentary conversations, public debates, dialogue, domesticating and the report much more importantly, and supporting the different kinds of groups to generate policy white papers on this process. The third action for me will be mass media and social media. The media are not just passive channels of information, and I know that many of our professionals are here. They're not just passive channels of information. They support the stuff that shape our thought process and our actions, and therefore is a robust engagement of the media will be very important. While I know that they are on this group, and we cannot go into full details of the nuances of how to engage with them to deploy the knowledge, the action that are there. I think we have to do that a little bit at different fora, and I think Moji will have to work towards the process of doing that. But they can transfer salience on these issues. They have been doing it, but what we've had is that it hasn't been sustainable. I remember those days when I was in UNICEF, we continued to engage with the media, and 30 years down the line, we're still talking about engaging the media. So we have to engage them to be able to inform public agenda, inform public opinion, and shape the kind of policy space that we have. But we also know that sometimes the policy media coverage and advocacy sometimes doesn't translate into policy change. So that kind of interaction will be very critical for us as the channels of communication. Within the media space also is what the category called media gatekeepers. And Moji, you will know that even while we were NTA and many other organizations that we worked with, engaged media gatekeepers has been very critical. The various writers, correspondents, these people, editors who take editorial decisions and production decisions, they need to be able to engage, to be able to influence the PSA agenda that we are. And even in the social media world, we now have more powerful social media gatekeepers that are non-traditional, that provide alternative, non-mainstream news sources and news information for the public, and we really need to engage them. Therefore, in a digital age, we cannot afford not to effectively engage with digital citizenship, digital influencers to be able to work here in this area. So therefore, a strong partnership with them would be very important to ensure that there is accuracy of information on the process and the stories are effectively generated. Last 2 points will be mobilize the people. Of course, we must put people at the center of what we're doing. The report is about people. The report is about the challenges that people are facing. And of course, we must put them at the center. I recall those days in my work with USAID, FBA, and UNICEF. We try to ensure that either what we call beneficiaries, right holders, DT bearers have been part of the conversation, and being able to ensure that they feature prominently in the process is critical. Several times we have had them speak truth to power at local structures, at different structures, but sometimes they tend to be marginalized, or sometimes we just use them as public relations tools. This cannot be, we cannot allow this to continue. They are not public relations, they are individuals that we really need effectively for this process. So in conclusion, 2 more slides. In ensuring that we're able to do effective communication, we need to have a consistent narrative around health. This hasn't happened. We have a consistent narrative. Health, and this hasn't happened. We have. Sorry, I see that I'm already 8 minutes. I timed myself.
Thank you. You have 1 extra minute to finish up. Professor Fayoyin, have I lost you? Well, Professor Fayoyin, are you there? Well, I guess the last slide tells it all, you know, the message, the messengers, and the medium, knowing where to go, what to do, and how to engage with the media, and of course, with the messaging, the communications that will go a long way to enhance a robust preventive medicine. Yeah, are you there? Prof, have I lost you? Wow. Anyway, one thing I can promise all of us is that we'll get a complete set of all the presentations that have been made today. So we just go quickly to our next presenter. Our next presenter is Dr. Gafar Alawode. He's an experienced public health practitioner and a seasoned program manager. He obtained a master's degree in tropical medicine from the prestigious Liverpool School of Tropical Medicine, United Kingdom, after acquiring first degree in medicine and surgery in Nigeria. He's managed several donor-funded development projects, and still doing that. And today I would like Dr. Gafar, if you're there, I hope, yes, I saw you a few seconds back. Now, I would want you to speak to the publication, you know, recognizing the role of non-state actors in translating the findings and recommendations into implementable government policies. Now, as a co-convener of the Universal Health Coverage 2023 Forum, what does this report mean to you as a person, and how would it help you to put universal health coverage on the political front burner? I think this question is also coming from me. So please, you have the floor, Dr. Alawode.
Okay, thank you very much, Auntie Moji. Can you hear me, please?
Loud and clear.
Okay, thank you very much. First and foremost, I would like to thank the Lancet Commissioner for the great work of generating the needed evidence to transform the health system landscape. We believe that to reform, we must be informed, otherwise we will deform, and that is why it's very important to generate needed evidence. So I thank the Lancet Commissioner because this report is very timely. It's coming at a point where some of us are coming together to form what we call Universal Coverage 2023 Forum, which is a platform that brings stakeholders from wide array of a background, because we believe in taking advantage of the policy reset window that comes with general election to put a universal coverage on the political front burner. And we want to ensure that we do things differently in 2023 so that we'll be able to put health on the political front burner. And how has the report helped us in this quest for putting health on the political front burner? So there are two important aspects where this report is very important to us. One, it generates evidence for us to articulate what we call health agenda or health manifesto. Then two, it brings credibility to the manifesto that we are talking about. And what do we mean by health agenda or health manifesto? All of us believe we should put health on the political front burner. Then when you are talking about to the politician, what exactly do you want to put on the political front burner? And this is what we are trying to articulate as health agenda. And how has this Lancet Nigerian Commission helped us? Like I said earlier on, it's to help us to generate evidence. And we are looking at this health manifesto or health agenda in two aspects. One aspect is that what are the strategic shifts in policy that we want to sell to the political class, to the political party, and the flag bearers in the next election. And the next thing is that what does the result look like? What does success look like? So in terms of articulating strategic shifts for health in the health manifesto that we have developed, because we started a participatory process where we brought the political parties and media, policymakers, lawmakers, and everything to look at what should we prioritize. And one important strategic shift which we are looking at, which we are able to find evidence from the Lancet Nigerian Commission, is what we call policy and resource optimization. And when Professor Obaka spoke, when Professor Obina spoke, and Dr. Iberi and others, they alluded to the fact that huge inefficiency in the system in terms of our resources, man, money, and material. We are not getting optimal results. So we want to articulate a strategic shift around resource and policy optimization. The policy angle is there are a lot of policy trusts we have in Nigeria that we're not actually optimizing them. One key example is the certificate of standard that is the National Health Act, if implemented, which has huge implications for achieving improving quality of the healthcare delivery. Then a second area in terms of the strategic shift we are talking about is sustainable finance and strategic purchasing, again, which has evidence from that document, And then we are looking at raising the accountability bar. All the speakers, the Lancet Commissioner, they talk about raising the accountability by ensuring that our systems are accountable, the policymakers are accountable, and everybody's accountable. So we're looking at that aspect. And we're looking at the area of citizen engagement in terms of how do we ensure that we effectively engage the citizen so that we'll be able to, it's not enough to say PCA Care Provision Fund is there. Even when people register and they don't even come to access the care because they don't have an understanding of what they stand to gain. Then we are looking at the area of policy in all, health in all policy. And the strong evidence for that is that if you look at the MDG errors, half of the reduction in the maternal and child deaths that we saw were actually attributable to efforts outside the health sector. So we'll be searching ourselves, we are not working effectively with other sectors. Perhaps probably the most important, that's very strategic for all what I've said earlier on, is the issue of having a very, very strong institution. And when I talk about strong institution, I mean both service delivery institution, administrative institution, regulatory institution, and training institution. We cannot have an 18th century institution and expect them to deliver on 21st century development agenda. So we are working on a sort of a strategic repositioning or corporate repositioning of our institution as part of the strategic shift that we are selling to the political class. And then we are trying to define the result along universal recovery progress on primary care systems and strengthening demographic dividend and higher level of care and health security as well to define those. After defining these, the next thing is that we use it to engage the media, like Professor Faye said, but more importantly, to engage the political class. It's very, very interesting that the representative of our PDP and APC were part of the health agenda development process. And there was a very, very striking comment that some of them, one of them made. It said, this is the first time that the policymakers in the health sector are engaging the political parties. It's very, very, very interesting. So we want to engage at the leadership for the political level as well, and engage at the level after the party primaries to engage the candidates of the major political parties to present agenda to them, and again, use to engage the citizen as well, so that citizens will use that one to demand for accountability. And after the election as well, we form the premise for engaging others. And we're working with other people, we're working with the Chatham House to ensure that we're able to achieve these objectives. So I really thank the Lancet Commissioner again for providing this evidence, and we hope that this time around we'll take advantage of the policy research window that comes with the general election to do things differently. Thank you very much.
Thank you very much, Dr. Gafar Alawade. Quickly, I would go back to Professor Ibrahim Abubakar, our lead discussant today. And I'll just like to bring you back. The paper proposed an ambitious program of healthcare reform to deliver a centrally determined and locally delivered health system, given the federal nature of Nigeria and the complex political economy of federalism. Now, how do we achieve this? How best can we harness private sector potential to transform the country's health sector landscape? I'm sure I'm mixing both together, but I'll yield the floor to you, Professor Abubakar.
Thank you. I will attempt to answer both questions, but before I do so, I'd really like to thank you, the organizers of this meeting, and all of the speakers for providing the platform to discuss in detail some of our recommendations and begin to think about what does it mean and where do we go from here. So thank you again. So to tackle your question, yeah, Nigerians love exceptionalism. We like to think of ourselves as special because partly it makes us feel good, but partly it excuses our failings. And of course, we are special in so many ways. I mean, whenever one is in Nigeria, the dynamism compared to everywhere else and in the world, and our ability to face adversity is unique in the world. But in doing so, we forget that actually we are not that exceptional or unique. And that is why in the report, we look at other systems that are equally complex and produce case studies from them. For example, India, where in fact they have the same level of complexity, if not more, and are able to do things a bit better than we are. They have their own challenges, but there are areas certainly such as the coverage of their health insurance. They are making strides and moving in the right direction. So we have a lot to learn, and we cannot use the excuse of the stratification of the system, which we accept is a challenge, and which we may all have our own personal views about the best structure of federalism and how Nigeria should be structured. But the truth is, it goes beyond health, and it is what it is at the moment. And while we should each advocate for a better system for the future, the health economy and health actors need to recognize that and do the thinking necessary to make the current system, the multi-tiered system, work for health. And for that reason, within the report, we put forward this recommendation of thoughtful centralization and appropriate localization, accepting that there are certain things that are better delivered by the federal government and that we need to think through those again to make sure that they're the right ones, and that certain things that are best delivered locally. And some of those local things would require a greater level of accountability than we have at the moment. And one of the greatest challenges and one of the biggest feedback I have had is this issue of, do we really need more report and more thinking, or do we just need implementation? I would argue that actually we need both. We need implementation, but to implement and keep doing the same things the way we've always done them means that we're not taking a step back to think about how do we do them differently? How do we make sure that we're injecting enough intellectual capital and space to deal with the reasons why the current system does not work? I mean, I remember this anecdote told to me during my last visit in Abuja about why certain local systems don't deliver, in that the procurement system is so corrupt that the people awarding the contracts, as well as the people delivering them in the private sector and the store offices and the clerks receiving them in the health care centers, are all in cahoots with each other. Now, the only way you can break that is by taking a step out and thinking and spending more intellectual time than those people trying to break the system, and thinking, how do we block and make it more difficult to do so? And that is not necessarily by changing the entirety of the structure, but by dealing with the problem, whether it occurs at the local, state, or federal level. And I think that both implementation and challenge requires more, not less thinking. And we cannot use our complex federal system as an excuse for failing to deliver. Now, to answer your second question, which is how can we utilize the private sector more? I think the first step in doing that is kind of identifying and defining and accepting that the private sector is more efficient at doing certain things, and that we accept that the private sector has a motivation, i.e. people invest capital in a company or a business with the primary motive of returning profits to the owners of the business, to the shareholders. And therefore, for it to function for the people, the state has to govern the private sector better and have better regulations and monitoring when it delegates responsibility for things like healthcare to the private sector. But then the state must also identify the things that the private sector can do more efficiently. Manufacturing, the world over, is better delivered by the private sector. We know that supply chains, while the state can do them sometimes, the private sector is good at innovation and shifting its focus so that it deals with challenges in a way that is more agile than often the state can do. And there are certain specific services that require innovation that are also better delivered. But in all those cases, the state has a responsibility to deliver. Above all, I'd like to suggest that we need to think again about innovation, even in our relationship with the private sector. And I would like to draw on the ideas of my colleague, Mariana Mazzucato here at UCL, who put forward this thesis of mission-oriented innovation, where the state decides as a whole what they want delivered, and then it governs all of the elements in the private sector that needs delivery. But in return, it asks for a share of the profit from the private sector to do more for the people. And that sort of narrative then allows you to make sure that the private sector is working for the people while it makes profit, but that it is doing so in such a way that there are good returns for citizens and the country. I hope that addresses your question, and thank you once again for the opportunity to present and discuss this report. Thank you.
Thank you so very much, Prof. Yes, it does, and I'm sure that as we go on, the conversation will continue. At this moment, because our time is fast spent, we will go to the chat room and hear some questions. Maybe I have about 2 here with me. And the first I'm going to read out is from Robert Yates, Chatham House, who is also collaborating with UHC 2023 here in Nigeria. Thank you, Rob, for being there. I saw you at the very, very beginning. Now, let's go straight to, would I say a comment or a question? And I wonder who, any of the panelists or our lead discussant can actually speak to it. This, you said throughout history, major universal health coverage reforms have always been led by political leaders who have rapidly increased public financing for health to replace out-of-pocket funding. Will Nigeria's universal health coverage hero emerge from the presidential election, and who will this be? Great question there, and any of our panelists can please react to this. From Robert, yes.
Okay, Obin, I can react to it.
Okay, go ahead, Prof.
Yeah, well, I think definitely we need to push this health agenda more, and then make use of, show that the money we have makes a lot of impact. I think such evidence will help the champion to produce more money. So I think the challenge for the health sector right now is to show even the money that has been released for basic healthcare provision fund, what have you achieved with it? This will create the ground for more money, to ask for more money. So because politicians will always point to the basic care provision fund. So I think let's get that evidence ready and show we have been able to cover so many lives with these billions. We need more money, or we show evidence that even with this amount of money available, this is the maximum we can cover. I think that will stimulate or motivate these political leaders to do more. So we need evidence, and economic evidence, to wet the ground for this to happen. Thank you very much.
Thank you very much, Prof. Evidence needed to ensure that what the resources at hand are well utilized. And I would just like to put in a word here that we're hoping that UHC 2023 will be able to, get the political will that is needed to ensure that health is put on the front agenda. That's what we intend to do. Now, speaking about who the UHC hero whether will emerge from the presidential election and who will this be? I'm not a seer, so yes, Ebere, Yes, please. Ebere would like to comment, and yes, please. Dr. Ebere,
Yeah,
you have the floor.
yes. I'd just like to say that actually, I'm not sure we need a hero right now. What we need is the public, because politicians respond to, they are supposed to respond to what the public wants. The problem we've had in the health sector is that we don't know how to speak to the public, how to engage the public. Because if the public take this as a big priority, then we expect that politicians will respond to that. And that's, I think, what we need to focus on. So using really strategic communication, explaining things to the public in the ways that they understand. I think that the health sector has been too technical in the way that we communicate what we are doing. And I think that needs to change. If we can engage the public, then it's the public's responsibility to engage their political leaders, and it's the political leaders' responsibility to respond to that demand from the public. I think the BHCPF gives us an opportunity to do this, and I think that's probably what we need to focus on. Thank you.
Thank you very much. We need to engage with the community, citizens, especially, well, in terms of seeking demand, because Nigerians don't make enough demands. You know, we're very resilient about health, and the politicians get away with this. But this is what we are trying to change within the context of the UHC 2023. And I think Professor Fayoyi alluded to that in his presentation. I'll take the second question from Dr. Ishak Lawal, Executive Director, End Cervical Cancer in Nigeria Initiative. Now, the question is, how can the findings, the findings in the Lancet Commission help align specific health targets, for example, cervical cancer elimination strategy, into a pool of efforts towards achieving universal health coverage in Nigeria? Any of the panelists can take this, and let's have answers for this. I have not seen any hand up.
Okay, Auntie Moji, can I come in here?
Yes, please. Okay.
Okay, thank you very much. So quickly, in terms of the health agenda being articulated, looking at the results areas, because if you look at the body of disease in Nigeria, emerging body of disease, and what we need to pay attention to. The issue of higher level care actually came up as well. And the higher level care, we are looking at some chronic diseases, some conditions that make more people to spend more, and they can impoverish them. So we are looking at one, the existing scheme like Cancer Health Fund and others. How do we raise the accountability bar? Because the report is talking about we have to raise the accountability bar. How do we raise accountability bar for that as well? How do we ensure more money is going? But before more money, how do we ensure that even the existing money that is being allocated is being spent well? The way our comprehensive cancer center, how optimal are they in terms of our performances as well? So some of those things are articulated in the 8th agenda that we are trying to articulate. That's what I would like to say for now. Over.
Thank you, Dr. Gafar. I'll take this as the last question from Kenneth Yakubu. What is the place of human rights norms and laws in strengthening accountability to reforms recommended in this report? Again, I'll take that. Maybe I was too fast. What is the place for human rights norms and laws in strengthening accountability to the reforms recommended in this report? Is our lead speaker still around? Professor Obina.
Okay, well, I can.
Yes, thank you, Prof.
Well, I mean, the issue of social justice is quite, taken care of within the report, because it's understood that without social justice and human rights, you cannot achieve much. Because I mean, the idea of advocating for the government to buy health insurance premium for 83 million people that are poor, you know, is an issue that has to do with human rights and social justice. So there are, you know, it's an underpinning of the report. I think that's the point I want to make on this question. Thank you.
So if I may add to what Prof just said, I think the report was very clear about promoting the issue of a social contract between the governed and the government. And the issue of central to the issue of a social contract, the issue of human rights, because it talks about the role, responsibility, and the rights of both citizens and the government as well. So I think the issue of human rights is very central. So I think we just need to do more to put that in practice to ensure that our thinking around human rights, we actually get it right, working with some existing organization like National Orientation Agency, because it's actually an orientation issue in terms of how to ensure that we attach importance to human rights. Over.
Well, thank you very much. More questions are coming in, but truly and truly, our time is up. And well, this is a continuum. We hope that we would continue to engage using several other platforms in dissecting this wonderful publication that is giving us a lot of leadway to how to do things differently and get results. It has been an interesting conversation this afternoon. We've spoken to a variety of innovation going forward, pointing out where the weaknesses are and where the strengths are, and of course, what to do to achieve results. Strategic shift around optimal use of resources, management of resources, prevention in terms of a quick win to improve healthcare, to improve health of the citizenry, multi-sectoral partnership, raising the accountability bar, citizens engagement, how best to engage with what to communicate, and using the media as a gatekeeper, or we use them as an amplifier to ensure that health messages got into the people that will arouse some measure of demand. Human rights management, and of course, equity in health, innovation, digitalization, and of course, human rights. It's been a wonderful, wonderful 2 hours of learning and translating knowledge into action. I'd like to, on behalf of DGI and ISMPH, to thank our lead presenter. I'd like to thank our lead presenter, Professor Ibrahim Abubakar. Thank you for your time. I'd like also to thank immediately Professor Obina. Thank you for staying through. The Executive Secretary of the National Health Insurance Scheme, Professor Nasser Sambo. Thank you for your time. All the time we knock, your door is opened. Dr. Amina Baloni, thank you for what you're doing in Kaduna and how you've been able to cascade some of the findings to ensure that even the most vulnerable are reached. Dr. Ebere Anyachuku, thank you for all the time committed, and more than anything else, being there to ensure that we have a sustainable healthcare delivery system in the country. I cannot but say thank you to my own constituency as delivered through Professor Bayo Fayoni. That has been wonderful in spite of the fact that network misbehaved like is expected. But thank you for how far you took us, and I'm sure that will be in the recommendation going forward, engaging appropriately with the citizens to create demand, particularly with our politicians. Dr. Gafar Alawode, I want to thank you most sincerely for always ready to promote healthcare delivery in Nigeria using every platform. And as co-convener of the UHC 2023 forum, we now know that there's so much to do, but they are all doable. For all the participants all over the country, and of course, our very own Chatham House collaborators, we thank you so much for being part of this historical maiden edition of this program. It will happen again in May. And we hope that in May, we'll have more of you here with us. For today, we have attempted to translate knowledge into action. And so on behalf of every member of our team, thanks for staying there, but health begins with you. So ensure that you also become not just an advocate, but ensuring that individual responsibilities, government responsibilities at every level are also put in place, and ensure that Nigerians demand for good quality healthcare that will translate to universal health coverage. Thank you very much. My name is Mojima Kojola. It's been a wonderful experience. Have a good day wherever you are.